thank you, Dr. Sifali's team for excellent presentation. I mean, pediatrics, they are always very bright presentation. So now we'll have a surgical presentation, but try more of obstetric. So we have got an unusual case of ITP. You may think that ITP is what is so great about it, but this case has unusual complications with pregnancy. So good thing about pregnancy that anything can be associated with pregnancy, all medical, surgical, neurological and all. So we have Dr. Ipsita is our senior resident, AIIMS throughout. She will present the case, and Dr. Rajesh Kumari, our faculty, she will discuss the case, and we'll have inputs from pediatrics as well as from hematology department. So Dr. Ipsita, please, let's see what is so unusual about this ITP in pregnancy case. Thank you.
Thank you, sir. Good afternoon, everyone. I'm Dr. Ipshita, and I'll be presenting the CCR from the Department of Obstetrics and Gynaecology. Our topic is chronic ITP in pregnancy, atypical presentation and its novel management. Coming to the case summary, the patient is Mrs. X, 23 years old, resident of Darbhanga, Bihar. She was a third gravida, para 2, no live issue. She presented on 7th of Feb 2020 at 14 weeks period of gestation with a provisional diagnosis of ITP. She was married for 7 years, and the first pregnancy was in 2015, which was a spontaneous conception. There were no antenatal complications, but she was evaluated at 5 months period of gestation for anemia. She received blood products. Then she delivered full-term vaginal delivery in a hospital, but the baby was unfortunately a fresh stillbirth, and she received 2 units of PRBC in the postpartum. The second pregnancy was in 2017. It was again a spontaneous conception. She underwent a full-term cesarean section in view of meconium-stained liquor along with fetal distress. This baby was a fresh stillborn, and in this also, in the postpartum period, she has received 3 units of PRBCs. Coming to the menstrual history, her cycles were regular, and she has a history of easy bruisability, gum bleeding, prolonged bleeding from injury sites in her past history. She was diagnosed to have thrombocytopenia in 2019 when she had AUB, and she consulted a private practitioner there in Bihar, and she underwent a bone marrow aspiration, which was suggestive of marrow with erythroid hyperplasia and megakaryocytes. These are her baseline investigations at the time of her presentation. Her HB was 10.6, platelets were 5,000, and peripheral smear was suggestive of few large and giant platelets. The rest investigations were normal. There were no splenomegaly on ultrasound. Coming to her management, initially we got her evaluated from the hematology department, and she was admitted. 4 units of random donor platelets was transfused, and she was started on oral prednisolone 20 milligram once a day, and along with that IVIG was given 1 gram per kg per day for 2 days. After 3 days of therapy, her platelet count increased to 35,000 per ml, and she was discharged on oral prednisolone 20 milligram once a day. But this was not all. She later had a very turbulent course and presented again at 19 weeks, 24 weeks, and 26 weeks period of gestation. In 19 and 24 weeks period of gestation, she presented with epistaxis with a platelet count of 2,000. Again, she received multiple RDP transfusions, IVIG, second cycle was given, and the dose of tablet prednisolone was increased to 50 milligrams per day. At 24 weeks, again, she had a platelet count of 5,000. She was given the third course of IVIG. The tablet prednisolone 50 milligram OD was continued. This time the response was better, and the platelet count increased to 32,000. But at 26 weeks period of gestation, when she presented with epistaxis, she received 13 RDPs, the 4th dose of IVIG, and the platelet count increased to 20,000 per ml. We kept the patient admitted after 26 weeks period of gestation. At 27 weeks, she complained of lower limb pain, more on the right side. It localized from mid-thigh to mid-calf. It initially got resolved on oral analgesics, but later required injection paracetamol and injection tramadol. Over the next 1 week, pain progressed to bilateral hip joint with increasing intensity, and she developed antalgic gait. We had few differentials on our mind. DVT, which was ruled out by Doppler. Soft tissue hematoma, which was ruled out by ultrasound. We thought it could be sciatica, lumbosacral compression, or avascular necrosis of bone because she was on high dose of corticosteroids. We decided to go ahead with MRI of bilateral lower limbs. I would now like to call upon Dr. Zainab from the Department of Radiology to discuss the MRI findings.
Thank you, Dr. Ipchita. Here we have the MRI coronal T1 as well as STIR images, which are shown here. In both the images, we can see that there are various altered areas of signal intensity, which are serpiginous in nature, as can be noted here, better seen on the coronal STIR images, which are predominantly located in the diaphysis of bilateral femur, more on the right side than the left side. Along with that, also on the right side, we can notice here that there is soft tissue edema intramuscular, which can be noted here predominantly in the middle third of the thigh, as well as periosteal thickening, which is further more predominant on the right side as compared to the left side, which is noted. On the axial T2 images of the right thigh and the left thigh respectively, we can better appreciate these areas within the medulla of the bones, which are serpiginous with a peripheral hypointense rim and a central hyperintense foci, which is a typical double line sign that is described with avascular necrosis of the bone. So just to summarize, bilateral intramedullary diaphyseal focal lesions likely suggestive of AVN. In addition, we have soft tissue edema as well as periosteal thickening more on the right side, which could suggest a diagnosis of osteomyelitis complicating bilateral AVN.
Thank you, Dr. Zainab. So we reached at a diagnosis of bilateral avascular necrosis of femur with superimposed osteomyelitis on the right side. An orthopedics consultation was done for the patient, and hematology department was involved to revise the management of the patient in view of corticosteroid-induced complication. Coming to management, the osteomyelitis was managed with IV augmentin, 1.2 gram BD for 7 days, followed by oral tablets for the same for the next 7 days, a total of 14 days of treatment. The pain was relieved through IV analgesics. For the ITP, prednisolone tapering was started at 28 weeks period of gestation at the diagnosis, and it was gradually stopped at 30 weeks period of gestation. IVIG, the 5th cycle, was given. The 4th and 5th cycle were given, one at 29 weeks and 31 weeks period of gestation, around 15 days apart. And the platelet count did not improve despite this, and she had a platelet count of 8,000. So we had to think of another alternative here. For the prevention of fractures, bisphosphonates, that is tapalendronate, 70 milligram oral weekly, along with vitamin D and calcium supplementation was started for the patient. Our immediate concern was how to maintain platelet counts at safer levels. We had to stop steroids because of the underlying AVN. There was no response to IVIG. We started bisphosphonates, the risk versus benefit. We had limited literature. The second line options included injection romiplostim and oral L-Trombobag for the management of ITP. We went ahead along with romiplostim after discussing with the hematology department. It was a newer drug which was used in pregnancy. The dose was started at 3 microgram per kg per week subcutaneous, was gradually increased to 6 microgram per kg per week over 3 weeks. It is a thrombopoietin receptor agonist. As we all can see, at 28 weeks, the platelet count was not above 10,000. At this time, romiplostim was started. The counts gradually improved, and it reached to a maximum of 50,000 at 35 weeks period of gestation after starting romiplostim for 3 to 4 weeks. Continuing with management, at 32 weeks period of gestation, steroid cover was given for fetal lung maturity. And at 35 weeks period of gestation, while the patient was admitted, the patient developed sudden onset antepartum hemorrhage. And per abdomen, the findings were normal, but the local examination revealed extensive bleeding. And at that time, the fetal distress also was detected. She had the baby had bradycardia up to 90 beats per minute. So an emergency LSCS and a GA was done on 8th of July 2020. She received 1 STP and 4 RDPs perioperatively. Intraoperatively, there was thin MSL. The blood loss was 600 cc's. In the post-operative course, there was no PPH. Injection romiplostim 250 micrograms subcutaneous weekly was continued, and tap olentonate was continued. The post-op HB after transfusion was 10.2, and immediate post-op platelet was 65,000, which gradually improved to 1 lakh on post-operative day 10. But on postpartum day 22, she developed bleeding per vaginum. Ultrasound abdomen was done. The uterine scan was normal, but the platelet count at that time was 3,000 per ml. She received her 6th course of IVIG along with 4 units of RDP. The dose of romiplostim had to be increased to 500 microgram per week subcutaneous, which is around 10 microgram per kg per week. The patient was discharged uneventfully on postpartum day 35 on the same dose of injection romiplostim, although her platelet count at the time of discharge was 10,000. She was advised hematology follow-up at this time. I would now like to call upon Dr. Tausif from the Department of Neonatology to discuss the fetal outcome.
Thank you. Good afternoon, everyone. I'll just try to sum up the NICU course of the baby in 2 slides. So basically, the baby was born 34 plus 6 week with a birth weight of 2150 grams and cried after initial steps, and female baby, and Abgas assigned were 8 and 9. So as you can see at the graphs here, the platelet count remained almost always about 10,000 despite multiple therapies. So the cord platelet was around 8,000, and we followed it up with a platelet transfusion. And day 3 to day 5, baby received the IVIG, total dose of 2 gram per kg. And still the platelet counts remained around 10,000 only, and followed up with multiple platelet transfusions, total of 4 RDPs during the stay. And then I was given IV methylprednisolone for 5 days, and following which again there was limited response, and we had multiple platelet transfusions. So working at this point, we were possible to autoimmune thrombocytopenia, which is explained by the ITP in the mother. Also, we were considering due to the severe thrombocytopenia refractory to treatment, we are also keeping the possibility of autoimmune thrombocytopenia, since mother was ICD positive at this point. And so these were the 2 working diagnosis kept. Although, and here on day 8, there was an additional complication. The baby was having prolonged oxygen requirement, and day 8, baby, on chest X-ray, baby was found to have a collapse, and we had done a screen was negative. However, on clinical grounds, it was kept as a sepsis, and we had started antibiotics and sent the blood culture. We had started on piperacillin tazobactam and amikacin and blood culture. So unfortunately, blood culture grew the Acinetobacter baumannii, which was sensitive above to piperacillin tazobactam and amikacin, and we planned to give antibiotics for 21 days since LP could not be done in view of low platelet counts. And then followed up with multiple platelet transfusions. A double volume exchange transfusion was done thrice to remove the antibodies circulating, and along with multiple platelet transfusions and a second dose of IVIG on day 24. So next, after the following the after on 26 postnatal day, after a dose of methylprednisolone, 2 doses of IVIG, multiple platelet transfusions, the platelet count improved. And on day 28, the platelet count reached day 29, platelet count reached 1 lakh. Since then, we had stopped the antibiotics, and respiratory wise also we could wean the oxygen by day 35. Since then, the platelet counts have been above 50,000, between 60-70,000, and towards the end of discharge, it was around 1.3 lakhs. So baby was discharged on day 51, and on follow-up, the baby otherwise is well and had a platelet count of 1.7 lakhs. And so this was quite a difficult NICU course for the baby. Neonatal course in NICU. So I had written NICU course. So this was I think she has made some changes. So and so the final word on platelet refractoriness. So this is our tool. We can study the corrected count increment, the absolute increment into the body surface area of the baby by the absolute number of platelet transfer. There's the amount of platelet in the bag. So for example, on day 14, the baby had before transfusion had a platelet count of 3,000, and after 24 hours post transfusion had a platelet count of 7,000. Taking the body surface area of the baby as 0.17 and bag platelet is 16 to the power 10, so it comes to around 1,000. So less than 5,000, it is taken as platelet refractory. So baby well evident from the clinical course. This is another way of documenting the baby had a refractory platelet refractoriness. So now over to Dr.
Thank you, Dr. Tausif. I'd like to invite Dr. Rajesh Kumari for the discussion part.
Thank you, Ipshita. Good afternoon, everyone. According to ACOG Practice Bulletin March 2019, incidence of thrombocytopenia in pregnancy is 7 to 12%. And these are the few causes which are most common causes of thrombocytopenia in pregnancy, like gestation hypertension in 80% cases, preeclampsia with severe features like HELLP syndrome in 5 to 21% cases, ITP, primary ITP and secondary ITP, and others. ITP characterized by impaired platelet production and T-cell mediated platelet destruction. And its incidence is 1 in 1,000 delivery. Now, what were the concerns regarding management of this patient and what we did regarding this case? So this was an atypical presentation, and this case was refractory ITP requiring high doses of steroids and multiple IVIG courses. And this was first case of steroid-induced avascular necrosis of femur in pregnancy with ITP. And there is refractory ITP in neonate. And we did prompt diagnosis and management of avascular necrosis of femur. And there was need of injection romiplostim as second line management of ITP and use of alternate in pregnancy. Now, few words regarding avascular necrosis. It is in situ death of bone segment or interruption of blood supply. Major risk factor is steroid therapy and rarely reported in patients with ITP. Most common sites are hip, femoral head, followed by knee, femoral condyle, shoulder, femoral head, and ankle, talus, rarely shaft of femur. Occurs in two phases, ischemic and necrotic phases, osteocyte necrosis, and repair and resorption phases, bone resorption, more, and formation, bone fracture, and corticosteroid affect both the phases. Pathogenesis of AVN in ITP on steroid therapy. There is increased chances of thrombosis in ITP, causes activated platelets, causes microparticles, and this will cause 50 to 100-fold more procoagulants and platelet aggregation and thrombosis. Corticosteroid causes bone perfusion interference and apoptosis of both osteoblasts and osteocytes and causes bone resorption and other comorbidities. Now, these are few case report of AVN in ITP, but none in pregnancy with ITP. During pregnancy, AVN has been reported in other autoimmune conditions like SLE on steroid therapy. Now, few words regarding use of bisphosphonate in women prior to or during pregnancy and lactation. This is research paper published from Greece, in which 78 mothers whose fetuses had been exposed to bisphosphonate before conception or during pregnancy, along with 7 cases of bisphosphonate exposure prior to or during lactation. But there were no serious maternal or fetal adverse effects. 7 cases of preterm delivery were reported and 4 of transient hypocalcemia of the newborn, in which mother were there was history of malignancy, and bisphosphonate was used in view of hypercalcemia secondary to malignancy. 8 spontaneous abortion, and there were 4 congenital anomaly. In one, there is 1 VSD not related to aldronate, 1 renal and cardiac anomaly. In 1 CTV, mother was diagnosed a case of osteogenesis imperfecta, and 1 Apert syndrome, in which gene mutation was done. Now, coming to the usual management of ITP in pregnancy, there are 2. Most commonly, we are using steroids and intravenous IVIG. No clear advantage of prednisone over IVIG, but initial therapy chosen on the basis of side effect profile, cost, and anticipated time before delivery, and clinician and patient's preference, because IVIG is costly. So when coming to the first line therapy, corticosteroids are first and usual treatment because it is effective in 80% cases, and but there are increased chances of gestation diabetes, hypertension, and preterm delivery, but it is cost effective. Coming to IVIG, this causes rapid response, effective in 80% cases, and effect lasts 2 to 4 weeks, but it is expensive. In this patient, we have given IVIG from GSSK beneficiary. Now, coming to second line treatment option, According to ACOG practice bulletin, women with platelet count persistently below 20 to 30,000 ml or below 50,000 as delivery approaches should be considered for second-line treatment. These are the few second-line treatment options: azathioprine, rituximab, thrombopoietin receptor agonist, this is newer drug, romiplostim, or oral formulation eltrombopag. And splenectomy, there is remission of ITP achieved in approximately 75% of pregnant women who undergo splenectomy. Now coming to these drugs, azathioprine, there is delayed time to response and maximum recommended dose is 2 mg per kg in pregnancy, category C drug, but it is expressed in breast milk, but there is no reported side effect in the baby. Very few, limited literature regarding these drugs. And rituximab is teratogenic in first trimester and increased chances of preterm birth. Now coming to thrombopoietin receptor agonist. This is second-line treatment for ITP and FDA pregnancy category C drug, eltrombopag oral and romiplostim subcutaneous. It mechanism of action is it activates pathway of platelet production in bone marrow through thrombopoietin receptors and increase platelet production up to 40 to 60%. Now this is expert review of hematology in Jan 2020. It said platelet count between 20 to 30,000 in a non-bleeding patient safe in antenatal period and equal to or more than 50,000 is preferred for delivery. IVIG treatment of choice in emergency situation or impending risk of bleeding when a rapid increase of platelet count is required. And regarding thrombopoietin receptor agonist administration considered only in exceptional circumstances and limited to the last trimester. And in newborns of mother with ITP, there are chances of intracranial hemorrhage observed in up to 1.5% of cases. Now regarding, when we review the literature regarding thrombopoietin receptor agonist, this one study published in Blood in August 2020, 15 pregnant women with ITP and 17 pregnancies and 18 neonates treated with either eltrombopag in 8 cases and romiplostim in 7 cases during pregnancy for at least 1 month. Indication for starting of these drugs, preparation of delivery in 10 out of 17 cases. In 77% cases, response rate with thrombopoietin receptor agonist. There are 29% preterm birth, but there is no cases of fetal loss. Severe neonatal thrombocytopenia reported in 6 out of 18 neonate and no difference between vaginal or cesarean delivery. Now, there is very limited data regarding thrombopoietin receptor agonist. These are the few case reports in which they use romiplostim or eltrombopag for treatment of patient with refractory ITP. Like in this first case report, they used romiplostim in last trimester in refractory ITP and count increased up to 80,000 and delivered vaginally uneventful, and there were no PPH and no neonatal thrombocytopenia. And in second case, baby developed thrombocytopenia and given IVIG and RDPs. This second case report by Rodriguez M. et al. In Platelet May 2019, they given IVIG initially and oral prednisone till 34 weeks, but at last in late third trimester, they used romiplostim for increase the platelet count up to 1.5 lakh in 1 week, and patient delivered vaginally, and there were no history of PPH neonatal thrombocytopenia. And these are few other case reports regarding romiplostim at 34 week in which they used romiplostim to increase platelet count, and there was no neonatal complication. So there is very few literature regarding use of romiplostim thrombopoietin receptor agonist. Now I would like to call Dr. Mukul to give his expert comment regarding this newer drug.
Thank you, ma'am, for the opportunity. So chronic ITP in pregnancy presents unique management issues. We are using drugs which we don't commonly use for chronic ITP. That is, the first line of treatment here becomes lower doses of steroids in combination with IVIG given on a monthly basis. This is seldom the treatment which we use for managing chronic ITP in non-pregnant patients. The second end options is splenectomy, which is approved but commonly performed either at the time of delivery or during the second trimester of pregnancy. Nowadays, in non-pregnant females, the use of splenectomy has far more reduced as compared to maybe 5 years back. The drugs like rituximab, dapsone, danazol, azathioprine, they are all available, but you don't want to use them in pregnancy for obvious reasons. TPO receptor agonists have been available in India now, eltrombopag for the last 5 years, and romiplostim for since around 2018. These drugs act by increasing the platelet production, which is the other kind of defect seen in ITP patients, in addition to the platelet destruction. So the problem with the TPORs is that the use their use in pregnancy, that has not been the evidence is not sufficient at present for the safe use. And in animal studies, even embryo lethality has been documented with very high doses. So as has been correctly pointed out, these can be used, but as a last resort, preferably in the third trimester of pregnancy and after proper counseling and consent with the patient. This is one of the cases which we did the counseling and advice for TPORs after we have exhausted the other resources. And since Dr. Chumba sir is here, he must be knowing that we again recently in somewhere this month, in the first week of February this year, we again had a similar patient who was refractory even to this, and we had to undergo the patient underwent splenectomy at the time of delivery after failing even TPORAs. So I just like to conclude that these are new drugs, but the evidence for use in pregnancy and in lactation is accumulating. They are not to be used left in en route, and to be used only after proper counseling with the patient. Thank you, Dr. Anish.
Thank you. I would like to request Professor J.P. Sharma sir to conclude this case.
So thank you very much. So this case highlights the multi-specialty approach, and we are really thankful to our colleagues, hematology colleagues. And I requested Dr. Chumba 3-4 times. They said, do splenectomy for a refuse. So I think we had to. So they say splenectomy is one of the good thing, and Dr. Jainab and all the specialties are the neonatologist, of course, and they had a stormy period. So ultimately, it was a very unusual case, refractory ITP with serious complication of AVN of femur. So I mean, it is well much reported. Otherwise, I think so early diagnosis and prompt treatment with antibiotic, analgesic, and alendronate has avoided femur fracture. But management dilemma was there. So I mean, we had to give steroid because the platelet count was not improving, and the steroid caused AVN. So then we had to stop the steroids. That's why this romiplostim came into place, and they helped us a lot. And but that probably caused thrombocytopenia and neonate. I don't know whether it was because of, it was because of ITP. Romiplostim couldn't help in that much. But counseling of the parent was then favorable outcome for mother and baby with multidisciplinary approach. So she had a very bad obstetric history. Both babies died previously. Must be intracranial hemorrhage or something, if I'm not mistaken. So at least this time we could give her the live healthy baby. So thank you very much to all the colleagues and all others. And I request Professor Sumesh Kumar to give some comments, sir. And later Dr. Chumba and Dr. Parveen, if you want to say.
The case has been extremely well managed. Being a chronic disease, over a period of time, they tend to develop anti-platelet antibodies. You go on giving immunoglobulin, steroid, and the platelet counts always remain low. And at delivery, one that platelet should be around 50,000. So this is a big concern. It gives palpitation to all of us in obstetrics that now we have to deliver now. So how do you usually manage patients where antiplatelet antibodies have formed?
So antiplatelet antibodies are very commonly seen in ITP patients. So it's like that is one of the part of the pathogenesis of ITP, that the antiplatelet antibodies are there. So there are two ways to outset them. You give immunosuppression to decrease the production, or secondly, you can, for ITP patient, you can increase the platelet production to a larger extent with these newer agents. That is the only way out, sir. Unfortunately, we avoid very high doses of steroids in ITP patients because of numerous complications and embryopathy which has been observed with high doses of steroids.